And welcome everybody to the premiere of the Sherlock Holmes and the Case of the Missing Evidence. I am your host, Bill Richland with Wound Care Gurus, and we are excited to bring this series to you. It is going to be a monthly series, so obviously you're going to want to follow us and keep up on that. But also, I want to throw out there that we would love any input from you as well, our viewers. We would love to know any treatments you're getting that you're just struggling with the evidence behind it. Is there any evidence? Because we will be more than happy to take that on and make it part of one of our future shows. So like I said, we would love input. You can Facebook message any of those things in that you'd like us to maybe discuss on Sherlock Holmes, or you can email us at customer support at woundcaregurus.com and just let us know if there's something you would like to see us discuss on Sherlock Holmes and dig into the evidence or lack thereof in future sessions. Like I said, this will be a monthly series, so our next one will be in December. So again, excited to kick it off. I'm going to bring on my co-host. You all love him and know him, the incredible Dr. Michael Miller. Hey, Doc Miller, how are you doing this evening?
Evening, Bill. Happy Thanksgiving. Happy Thanksgiving to our participants. It's an honor, as usual, to get here and share some thoughts and bust a few myths.
There we go. Excellent. It's kind of almost similar, like a little takeoff on your Mythbusters that you've done at conferences out there. And I know you've done a Sherlock Miller type thing where you kind of talk about different cases, difficult wound cases. So it's kind of a spin-off of the both of those. But our whole purpose here with Sherlock Holmes and the Case of the Missing Evidence is to really go after those common wound care practices. I like to say they fall under wound mythology because they just really don't have the evidence to support them. And tonight, our episode is going to be discussing everybody's favorites, Unna boots, Ace wraps, and Tubigrip. So to kind of start things off, I want to just start with a review of our venous system. I thought we would talk with just some basics to kind of lay out the format for our viewers and future watchers of this episode. I like to talk about the venous system as 3 P's, folks. That is, we have pumps in the calf muscles. Every time they contract, they are going to squeeze on the veins. And with a good, healthy calf pump, it can produce upwards of 300 millimeters of mercury of pressure on that vein. And that is going to really push that blood through that plumbing or through the veins. And the key thing we need to understand, as I've always discussed, and I know Doc Miller would agree with me, is that really when it comes to treating vein disease and managing venous insufficiency, we don't really need studies, because really it's just a matter of anatomy, physiology, and the laws of physics. All right? And this is what we'll do now. The first kind of laws we're going to talk about here is the second law of motion and Bernoulli's principle, which basically, in essence, says that a liquid is going to move from an area of high pressure to low pressure. So when that pump contracts and squeezes, it's going to push the blood away from where that highest pressure point is. But we have to have a pump to create enough pressure to move the liquid. And then, of course, the third piece is the plumbing, which are the veins. And as you can see on the slide, they have those one-way check valves, which allows the blood to only move in a unidirectional way. And that is upwards. And that is how, when you have all 3 of these P's working, you have an effective venous system. Doc, do you want to add anything to this?
Yeah, you're correct. You remember that we have 3 basic sets of veins. You have the superficial veins, and they bring blood back too. The problem is that when you do this, suddenly the superficial veins are now blocked. But blood can move back superficially. That's why we've got these. Of course, the deep system, as you so eloquently said, is where the rubber meets the road. But to get from the superficial to the deep, that's where you've got those guys called the perforators, aptly named because they perforate the fascia. And again, as Bill said, the way the muscle works is that muscle pump, gastrocnemius soleus, milks those veins, but you also need an encasing structure, and that's the fascia. It's like a vacuum cleaner. If you're trying to suction with a vacuum cleaner and you cut the hose, you've lost your pressure because now you've got a leak. So when you're talking lower extremity, that enveloping fascia, and granted 3 compartments, is what contains that pressure. So the muscle gastrocnemius soleus complex squeezes the veins, generates that pressure, it's encased, and the valves then allow that blood to go only one way. And or again, it's external to internal through the perforators, but everything is moving from distal to proximal. And that's the basis for how the venous system is supposed to work.
Exactly. Emphasis on the supposed to work. And unfortunately, as you know, with our venous patients, is you end up usually the problem starts with the plumbing. It starts to become dysfunctional. The valves don't work. And then, of course, you have the leakage of the blood backwards in there. And that increases intravenous pressure, which makes it harder to move the blood the way you want to because it requires more pressure now. And then as we'll talk about, when the veins begin to leak because of the higher pressure, you have the swelling, which then reduces the range of motion at the ankle from the edema, and that then impacts your calf muscle. And if you don't have any range of motion at your ankle, you can't really get a very strong calf pump. And then you're not producing that up to 300 millimeters of mercury of pressure. You need to really push that blood up those veins and fight against gravity. So anyway, so what I want to do next here, Doc, and I know you were going to kind of talk about this, is we thought it would be important to address the 3 basic objectives of compression. Why do we compress, or why do we need to compress our patients? So I'm going to pop up a slide here addressing the first objective, which is we have to create that graduated, sustained compression. I'm going to let you kind of expound on that, Doc, if you would.
Sure. I mean, basically, static standing, the pressure in the venous system is approximately 90 millimeters of mercury. That means if you stand and don't move, it's 90. Somebody young and healthy, when they engage gastrocnemius soleus with intact fascia and with good valvular competence, they're likely to squeeze that, generate the pressures you mentioned, blow that blood out of there, and they should be able to bring it down to a pressure of about 30 millimeters of mercury. That's why even for young and healthy people, nurses, therapists standing on their feet, we recommend a low compression garment like compression socks, 30 at the ankle to 20, because that helps control that normal venous leakage. However, in the feeble and elderly, such as myself, where I'm blessed with having 2 total hips and an artificial knee, so I know I've got lower extremity compromise, at least on one. So with all that scarring and other things, and loss of the fascial envelope integrity, probably the best pressure I can get down to is about 50 millimeters of mercury. So your patients with venous disease are going to have pressures with aggressive compression of that 50, 60 millimeter mercury. So if you compare it to just standard plumbing, you basically have a pipe in your house that's leaking fluid at 50 millimeters of mercury. And that's what you've got to address, because if you don't do that, you have continued venous leakage. And it's important to remember one thing. There's this popular misconception that veins are both bidirectional. Let me assure you it doesn't happen. Veins leak. You do not put water, fluid, blood, whatever back in. It's like the pipes in your house. If that pipe's leaking, you're not going to be pushing water back into that leaky pipe. It's just not possible.
Exactly.
The goal is treat the pressure, stop the leak, and then allow that lymphatic system to suck up all the stuff that's leaked out, the proteins, the liquid itself. And that's the scavenger. That's what we want to try and protect, is protect the lymphatic system. That's the be-all, end-all that solves all these problems.
Right. So just to kind of just sum up the first objective here, the graduated, as we have in the image there, you got to have a higher pressure at the bottom, and it's got to get less as it goes up, because again, we're back to second law of motion in Bernoulli's principle, is that fluids will move from high to low pressure. And if you don't have that graduated compression from your device, there's no reason why the blood would want to move back towards the heart. Is that correct, Doc?
Correct. That's it. Then it's also, if you remember, with compression and looking at that beautiful drawing, the law of Laplace, which talks about compression, circumferential, and radius.
Right.
But as the radius gets smaller, remember, that's on the denominator.
Right.
That means that the pressure gets higher. That's why the ankle pressures are always higher, because radius is smaller. And when you cube that, it decreases, making the top number larger and hence the larger. That's important to remember, because applying too much pressure at a short radius, such as the ankle, you then have risk of causing problems such as skin necrosis or irritation. So it's important to know what your compression is. At the calf, where you're much wider, you don't have to worry about law of Laplace, because your pressures are lower. Why? Because your radius is bigger.
Exactly. And then the second part to this, I just want to point out too, is the key word is that sustained. And that kind of brings us, you can't have intermittent as all the time, because it's the more sustained the pressure is, the more it is continuously addressing the pressures that Doc talked about, the intravenous pressure and the leakage, which brings us to our second objective, Doc, which is we've got to decrease the edema, and that's by basically you got to stop the leaking and enhance the lymphatic function. So why don't you address that a little bit in more detail for us?
Right. There's two concepts I want to start off by explaining, and those concepts are working pressure and resting pressure. Because remember, the life of your veins is 24 hours a day. They don't stop working, when you're resting. They continue to leak. They will leak less when you are supine than when you are standing, but they continue to leak. The damage continues. So to go to the basics, resting pressure is the pressure that is exerted on the leg by something when the leg is at rest. And that means that at static pressure, you're squeezing. And we'll talk about ACE wraps, but ACE wraps, for example, have a high resting pressure. When you put those on at rest, they're squeezing. In contrast, when you pump your calf, the ACE wrap stretches. And so the working pressure, the pressure of during engagement of gastrocnemius soleus, drops. And so you don't have the 50. So again, working pressure is when the gastrocnemius soleus is pushing the veins against that. That's working. And you've got to have that 50 in a patient that's having venous issues. Resting pressure, again, when they're at rest and there is no gastrocnemius soleus, you still have to have 50. So the treatment that you have, which we're going to talk about, has to address both the time when you were at rest and the time when gastrocnemius soleus is engaged, the working time. And that basically is called 24 hours a day. Otherwise, you're going to have venous leakage uncontrolled, because you're not addressing the 50 millimeters of mercury, or arguably 90 at rest. You're not addressing those pressures if you don't complete the whole cycle of treatment.
Exactly. And that kind of brings us to our third objective that we want to review quick, and that is, we got to improve the calf pump effectiveness, because right now, as you mentioned, most of our patients don't really have a very effective calf pump, do they?
No.
So if we don't get that calf pump working in a more efficient and effective way, you're never going to generate enough pressure to push the blood uphill against gravity. And that's kind of, a big issue with why. Those are the three objectives that we need to address when obviously we are treating our patients with compression. So with that, Doc, let's start and address and talk about some of our lack of evidence-based treatments that we want to discuss. So let's start with the Unna boot. So first thing, Doc, with an Unna boot, are we getting graduated compression from that device?
You're really not. I mean, because when you apply them, you're going to get initially at rest when you apply an Unna boot. An argument can be made, and realistically, that because you're applying it on the skin on a swollen lower extremity, you're going to initially start off with some graduation. especially when they work. When the calf muscle pumps, you're going to pump about that against that fixed Unna boot. And if you apply it at the appropriate compression initially, yeah, you're going to get some initial compression at rest, at resting pressure high, and then initially the working pressures goes up. That is until the edema goes down. Because once the edema goes down, as the way I put it, now the swelling has gone down. The Unna boot is no longer in contact. That means resting pressure now is back high. Your venous leakage returns. Working pressure with no contact is high. Venous leakage returns. And so you wind up with what I call the what's the name of that instrument? Well, the accordion.
Right.
And the venous leakage is not. Unna boots only provide compression arguably for about 8 hours.
Right.
So unless you're willing to change your Unna boot, and again, the Unna boot arguably is a zinc oxide paste wrap and then a cohesive bandage Coban wrap over it. That's the classic Unna boot. There's others, the Duke boot and other things, but they're all similar. Again, that's the problem. They provide a high working pressure temporarily. Yes, they provide a minimum of resting pressure initially, but after a few hours and the edema goes down, then those pressures abate. And yet there's still those who continue to use that. The problem is you're not addressing the underlying problems as we've discussed.
Right. And like I said, even with an Unna boot, for example, technically speaking, an Unna boot is only the paste boot. It doesn't actually include the Coban. That's an additional layer if you add that to the treatment. I know that often it's referred to as what you mentioned, the Duke boot. But if all you do is put that sticky paste wrap on there, you're not really getting a 100% to 50% drop in pressure in the leg. It's not really creating much graduated compression, which is a limitation to, objective number one. How do you move the blood? What makes the blood want to go uphill then if there's no graduated compression from your device?
Correct.
You very succinctly pointed out that when it starts getting loose, it's not going to work. And technically speaking, when you look at an Unna boot, as you said, a maximum of 8 hours, but even during that 8 hours, it's only doing really anything if their muscles actually working.
Correct.
And how many people are engaged in activity where they're actually contracting their muscles for a full 8 hours a day? Even a normal person's day, can they actually say that they are flexing their calf muscles for 8 hours? In a day? And let's be honest, we know that's not true. I mean, I'm a fairly active guy, and I'll bet you if you look at my day, the 16 hours that I'm awake, I don't think that my calf muscles are engaging for, if we timed all the time, 8 of those 16 hours, because you're sitting, you're driving, you're resting. And let's be honest, we know our venous patients ain't coming anywhere close to walking for 8 hours in a day.
Yeah, and then when you elevate the leg, the other issue that we all need to be cognizant of, quality of life. Because you say, well, when you're not pumping your leg, get your legs up. Well, one, sitting in a chair for a prolonged period of time, anti-quality of life, you have to shift and move. And even if you're pumping your legs there, when your leg is not dependent, the pressure is not 90 anymore. So yeah, you're moving the venous blood from distal to proximal, but there's no pressure gradient. You're getting minimal leakage. It's flat. You're not getting that pressure. The problem is you need to be addressing it when you have significant enough pressures that you're getting venous leakage. That's when you're treating it.
Right. And again, I got a question came up from one of our viewers, something about is sitting in a wheelchair at rest or only when supine? I think they're referring to leg elevation. And and I would say, and I think you and I would agree that sitting with your feet up, as long as they're still below the heart, that's not really elevating your feet.
Correct.
So it's going to be minimally beneficial for them to just put their feet up if they're still in a sitting position. It's got to be a minimum.
Yeah, you can't do that for a prolonged period. It's not possible.
Mm-hmm.
A little, any of us that have tried to sit there with our legs elevated just doesn't work.
Right. Exactly. I'm looking at here, sitting that said, just seeing if there was another question that came in. Nothing yet at this point. So going on then, so I think you kind of addressed this. Do Unna boots really, are they effective at stopping the leaking then?
No.
Right, because it's not continuously applying pressure that it needs to. It's not sustained, is it?
No, it's not. The only time that I have in our practice that we ever consider using a zinc oxide wrap is when I have a patient that has severe pruritus and we've got topical steroids and other things, and they are digging and scratching at their leg. We will then use it as a short interpositional layer, and the term I use is locking them up so that they cannot get to that. Okay. I will then try and apply some form of compression over it, recognizing that the non-compressibility of the zinc oxide wrap will limit me. But the goal is to keep their cotton picking hands off their legs, treat the pruritus, and that buys us some time. And that's probably the only time that I would use that kind of zinc oxide wrap. Interestingly, we see that in renal dialysis patients.
Okay.
They tend to be very pruritic. And so if you've got one of those, that would be a nice trick. The zinc oxide wrap, cover it, apply compression, treat your underlying pruritus, and then when they stop the itching, you've got control, then go with full 4-layer or 2-layer compression or the Velcro and elastic devices.
Gotcha. Makes total sense. And again, the last objective obviously is to improve the efficiency of the calf pump. And that would be the one thing that the Unna boot can do as long as it's in contact with the skin when the muscle flexes, because it's a completely inelastic option. It will force that contractile force inwardly when the muscle actually contracts. But like I said, as I've always kind of said with Unna boots, they really only work if the patient works. They really don't do much at rest. And without that graduated compression, it's not going to really benefit us. So let's take on our next one, which of course is the infamous.
1 second.
Yeah, go ahead.
The point is that I'm betting that some of our audience members are saying, well, guys, listen, this is all well and good, but I've used Unna boots for years and they work. And to that, my response is always the usual: because of or in spite of. The fact that we have all had and we can all report successes with that, the scientific evidence still says this is not the best way to go. The fact that it was what was initially done, yes, there are successes, but if you hold yourself out to be a wound care expert, then you're obliged to do the best evidence-based treatments that you can. And that's kind of where the rubber meets the road. It's not whether or not, it's how is the best way to do this based on the evidence.
Excellent. And I think we and I discussed this earlier. When you look at the compression options, and there are a lot of compression options out there today, they're on a spectrum, okay? And, with 4-layer is typically considered to be kind of the gold standard of all of them because it produces the highest amount of compression you can get from a bandaging system. Well, if that's on one end of the spectrum, Unna boots would be on the complete opposite other end as the least effective option. It's not that it's not an option. It's just not anywhere near a good option in the vast majority of cases that you're dealing with. Like you said, if we're going to give our patients true evidence-based treatment, then we should be looking at options that are truly addressing those 3 objectives: sustained, graduated, stops the leaking and reduces the edema, and improves the effectiveness of all of those things need to be addressed, not just one. What kind of, again, it's not like a smorgasbord of those 3 objectives. I'm just going to focus on this one. Yeah. We got to do all of them if you want to be effective in treating our patients. So let's bring up into the talk now the ACE wrap. Another one that's out there. What's your thoughts on that one, Doc?
Well, and again, going back to the concept of working pressures and resting pressure, when you apply an ACE wrap has a high resting pressure. It's long stretch. So you put that on. Now, the second problem with that is unless you are the world's most accurate machine, nobody can apply each wrap of an ACE wrap at the same compression. So you
Right.
wind up with what I call the banister look, right? You know, and then it goes down. And right where it might be too tight, too loose, it rolls. So that's the problem. High resting pressure. But when you pump gastrocnemius soleus, the ACE wrap stretches, and
Right.
so working pressure drops. So once again, you are only addressing 50% of the gastrocnemius soleus working resting cycle. Well, that's a problem. That's a problem. Because
Right.
again, you're not doing what you. And again, depending on how tight you wrap the ACE wrap, you could do big time damage to the ankle with the law of Laplace, because now you're putting more pressure on a short radius.
Right.
And two, if you apply it tighter, more proximal than distal, now you're obstructing. So now you're creating more swelling distal, because that venous blood, which is being pumped from 90 to 50, has to overcome an ACE wrap that may be applied at 50, 60, 70. That doesn't happen.
Right. Correct. And I want to just pop up. I highlighted an article, and I kind of put it into a little bit of a screenshot here for our viewers in Podiatry Today, in their article called "The Guide to Compression Dressings for Venous Ulcers." This was published back in February 2012. If you look at what they state in here about your ACE wraps, it's important to note that a bandage with too high of an elasticity, which is an ACE wrap. Long stretch bandages are said to be able to stretch from 150 up to 300% of their original length, and then ACE wrap is pushing towards that 300%. So because of that excessive elasticity, it provides, as Doc Miller talked about, too low of a working pressure. And if you're only addressing that, 50% of the cycle, and then they also kind of talk about the fact that, this variation can hinder venous flow due to uneven gradients that Doc Miller pointed out again. It looks like a spindle on your banister where it's all different sizes all the way down the leg. And then they confirm it right down here in the last line of this screenshot. ACE wraps are intended for short-term use, not for the treatment of chronic venous insufficiency. Yet people out there continue to do it, even though there is documented evidence that there is no place for ACE wraps in the treatment, in the effective treatment of venous disease. So that then brings us, Doc, to our last one that we want to discuss, and that is go ahead.
Yeah, and the other thing to remember is that when you apply an ACE wrap, you are applying something that is clearly overcoming capillary closure pressure, 32 millimeters of mercury. And the issue with that is, if you apply that in someone who has poor ankle motion, poor gastrocnemius soleus, you are applying it basically over bone, over tibialis tendon, over ankle, and you can create a heck of a pressure-based tissue injury, especially in someone paraplegic, quadriplegic, or very, very, very limited lower extremity motion. So it's imperative, as Bill has said, you make darn sure that they can move their ankle somewhat before any of this compression goes on, because that's really the rate limiting step. If they've got a frozen ankle, then you've got to come up with a better way. And there are other ways that we could talk about, but applying definitive compression, you're basically just putting pressure on tissue that's hard, and that's a recipe for disaster.
Right. It's going to be continuously sustained at a level that will be higher than capillary closing pressure. And all of us that are familiar with pressure-induced tissue injuries, we know that once you supersede 32, it's only a matter of time before you're going to end up with an ischemic injury in the tissue. So, wrapping it up, let's bring it down to the infamous and last of your favorite one, I know, Doc, is Tubigrip.
Tubigrip has, here in the state of Indiana, I just shake my head and shudder. I don't understand why, because we have all of these, and again, I apologize for sounding disparaging, but you got to call it what it is, to the 99% level. The number one treatment here at every wound care center in Indiana, without any exception, or almost any exception, in the centers, is Tubigrip. And we can't understand why. The home healthcare agencies are calling saying, we got a patient, we want to refer to you. Why? Well, they've got leg swelling, it's not getting better. And I say, well, what is it they're using? Well, they're coming from a wound care center. And I say, oh, Tubigrip. And they say, how did you know? Well, it's ubiquitous. Bill and I had a discussion before. Why are we seeing that? For those of you and Bill mentioned it, we did a Facebook podcast a while ago, a wonderful series talking about some venous issues,
Right.
dispelling some other myths during venous treatment, PAD, cellulitis, CHF, DVT, things that I don't want to rehash, but that I compress routinely without any hesitation. And in this case, it could be unevidence-based lack of knowledge paranoia that they want to apply compression but not risk any damage. And so again, 50 millimeters out, 90 to 50, 90 you pump to 50. And Bill, what did we agree that Tubigrip at its best single layer gives you?
Oh, maybe 20, 25 at best with a double layer.
Double is 20 to 25. Single layer Tubigrip, 8 to 10 millimeters of mercury. So you've got a vein pumped 90 to 50 in venous patients, 50 out, 8 back. To use the line from the famous Jim Croce song, you don't spit into the wind. You've got 50 coming out and you're pushing back with 8.
Right.
And they can't understand why these venous ulcers don't heal.
Right.
They can't understand why the swelling isn't getting better.
Exactly. Again, it's as I mentioned early on in the talk, is that treating vein disease is really just a matter of understanding the laws of physics. And when as when I teach my students, as I teach seminars and I'm talking about venous disease, one of what I call it Bill's 3 rules of compression, and one of the rules is the pressure on the outside has to be higher than the inside, or it's going to keep leaking. Period. Real simple concept. Again, back to second law of motion and Bernoulli's principle. Liquids go from high to low pressure. They don't go from low to high pressure. And anyways, if any of our listening audience has any questions about any of the topics we're talking about, the ACE-Wrap, the Tubigrip, and the Unna boot, feel free to throw them up in the comment section. I did not mention that earlier. But as you can see, those 3 devices, again, are they an option? Yes. Are they a good option? No. Okay? And as Doc Miller pointed out, our goal, if we are truly going to be evidence-based practitioners, our patients deserve for us to make every effort to put them into the best evidence-based compression devices that we can. So with that being said, Doc, what would you suggest are some good evidence-based options for our audience that really want to treat vein disease effectively?
You have the Cochrane report, which is a fabulous compendium, easy to look up. Cochrane, basically, they look at it's a European-based organization. They look at all of the scientific evidence, and we've mentioned them, earlier. And they basically say, based on our review of the evidence, here is what works, here's what doesn't work, here's the strength of the evidence. And so based on that, the evidence basis clearly supports the 4-layer systems where you have padding, you have short stretch, you have an elastic, a long stretch thing, so that you're getting both high resting pressure, low working pressure, high working pressure, low resting pressure garments, and then the encasement, which is usually cohesive bandage called Coban.
Mm-hmm.
The 2 layers, and I was privileged to do some of the early comparative studies, 4 to 2. The 2 layers work as well as the 4. When do we use them? Well, the problem with the 4 layers is that they're loose, they're light, and so when you have a leg that has a beautiful popliteal incurve behind the knee and a big calf, you've got a shelf to sit that 4-layer on, because for it to fall, it's got to stretch over that calf.
Right.
So when I have a good, beautiful calf and a beautiful popliteal incurve, we'll go with 4 layers. When I have a cone leg, that's not going to work, because as soon as that 4-layer gets the least little bit loose, it's dropping. Sure. At that point, we would go with either a 2-layer system. Why? They're a little more stiff. Each layer holds onto the layer before. Or you've got these lovely Velcro inelastic devices. You've got the Faro wrap, invented by my dear friend Wade Faro. You've got the Medi Circade, which is lovely. There's several others, and they adhere to what we've been discussing. They have enough elasticity so that when you are when it's at rest, they're squeezing, and when you engage gastrocnemius soleus, then you have the high working pressure. But more importantly, those other devices, they can be altered. So if they get loose, you can secure the straps of the Faro, the Medi, or the other one. They're easy to put on. And again, patients that don't like things on their legs at night, those are ideal, because if you put a 4 or 2-layer compression wrap on someone, they're living with it for, in my world, we change them usually twice a week if I can get away with it. We used to try once a week, but they fall down. So twice a week, that's also ideal in the home healthcare world.
Right.
Because that's maximized. Monday, Thursday, Tuesday, Friday, the patient can cut it off. They can bathe, shower, do whatever. Home healthcare comes in and rewraps it. So, to kind of mini conclude, the 4-layer and the 2-layer equivalent, the Velcro Inelastics, Medi and Faro. There's also a device that's got elastic straps. I apologize to the manufacturer for not remembering the name. Those are all lovely, lovely options. And then, of course, for preventing it from coming back, now you've still got the Velcro Inelastics, because you can't wear the 4-layer and 2-layer indefinitely. Medicare won't pay for that. Or then you can get into the compression socks. The problem with compression socks is that compression socks at, say, a 40 to 30 gradient, patients will tell you that a 40 to 30 gradient in socks always feels infinitely tighter than a 4-layer or 2-layer wrap, which is at 50.
Right.
I've never understood why that is, but it is universal. A 50 millimeter compression appropriately applied 4 or 2 always feels less tight than a 40 to 30 compression sock. So to get patients to wear those when we can, we usually go with a 30 to 20. It's not ideal, but it's better than nothing. And if that's what it takes to get your patients into prophylaxis, it's better than nothing.
Right. Like I said, yeah, I think it's always, some compression is still better than zero compression. And I think a lot of times, too, with your patients that don't like to tolerate the higher compression, I've always recommended a stair-step approach, where you start them with 1 layer, then you build them to 2, you build them to 3, you build them up to 4, so they acclimate over time. So it's not this no compression all the way to 4 layers, and then they wonder why, geez, that thing is really tight. Well, it's kind of supposed to be that way if you kind of acclimate them through the process. Now, we did have a question come in. We weren't really going to address it, Doc, and we won't have to get into it too heavily, but the question did come in, so we're going to address it. It says, what about a mixed peripheral arterial disease and PVD? What would you believe is the best compression treatment? If their ABI number is too low, compression is not suggested, yet some edema is noted. So,
yeah, we can hit this head on. This is one of my favorite topics because, and again, let me dispel. PVD is a term we don't use unless you're using the V for venous, because if you're using the word vascular, you're not using a term. It's either venous or arterial. Pick your shot. So assuming you're talking about venous disease in the presence of arterial disease, if you stop and think about the question you asked, if they've got that much calcification in their arterial system, then are you really think that you are going to be able to generate enough compression to crush calcium? More, if you look at the cross-section anatomy of the leg, do you mean to tell me that you're going to apply a 50 millimeter mercury compression wrap, squeeze all that skin, all that fat, all that fascia, and all that muscle down on 3 teeny tiny arteries and cut off the circulation? Pathophysiologically, anatomically, absolutely not possible. It just can't happen. Even if you could generate enough compression to do that, how long do you think it would take for your patient to scream in agony that you were crushing the life out of their leg? So if you're going to treat venous disease, treat it. We debunked that myth about PAD. In the history of mankind, I am not aware of a single case of anyone being able to apply a 4-layer or 2-layer compression tight enough to shut off the circulation. Physiologically, it is simply not possible.
Right. And again, I like to also say, I mean, again, we're back to basic, simple laws of physics. Okay? The pressure on the outside has to be higher than the inside in order to occlude the arterial flow. And,
right.
You and I addressed it. And for our person that asked the question, you can certainly go to our woundcaregurus.com website. And in our members only section, you can view our interview that I did with Doc Miller called ABIs and Compression Debunking the Myths. We get into it. But Doc Miller, what you said is completely spot on. And what I always like to remind people, if you look at the actual science, and limb occlusion pressure studies reveal that it takes at least a minimum of 250 millimeters of mercury up to 450 millimeters of mercury to occlude arterial flow in a limb, hence limb occlusion pressure. So if you've got to have at least 250, what is a 50 millimeter wrap going to do to cut off blood flow? And the answer is it's not. It cannot, because you don't have enough pressure on the outside to occlude the inside pressure, especially those arteries, as you mentioned, that are deep under all the skin, the fat, and the muscle.
Yeah, when I'm doing ABIs, when I get my blood pressure cuff up to 200, if I still have a Doppler signal, and remember, Dopplers are electromechanical, they produce a signal. You palpate a pulse, Dopplers give you a signal. But if I get to 200 and I still have a signal, the test is over. They got a non-compressible artery. That means it's a non-compressible artery. That means I can't compress it. That means I can now treat the venous disease because I'm only going to 50. Right. And remember, capillary closure pressure is 32 millimeters of mercury. So to quantify, you are only applying these wraps at 1.5 nail pushes. 32 is what it takes in healthy people to occlude the capillaries. So when I explain to my patients, I'm going to apply these wraps at 1.5 nail pushes. Now you've got a comparable, a way to compare what the wrap pressure is to something tangible. Sure. 1.5 nail pushes. That's all it is. Right. 50 millimeters of mercury.
Good. Yeah. So like I said, for our person out there, you do not have to worry about occluding their arterial flow with any compressive device unless you completely wrap it inappropriately. And even then, you'd have to put some serious effort in to create 250 millimeters of mercury of pressure with it. So we got another question that came in, Doc. And I think this kind of goes with what you're talking about. At what point do you choose to transition someone from a disposable compression into Velcro?
Fabulous question. And the answer is cost. It depends upon what they will pay for. Obviously, the Velcro inelastics, the Faro, the Medi, the other one, they're easy to take on, they're easy to take off. So when I've got and I tend to use those more, as I call it, for prevent it from coming back. Yes, you can treat with them, but just over years, I find I get better results overall with the 4-layer. Why? Because that way I control. When I'm treating, I control. Once the ulcer's healed, once the edema is down, then it's back to the patient. But I just think the Velcro elastics for prevent it from coming back prophylaxis, easy to take off, easy to put on. They don't have to wear them to bed. They don't have to shower with them. There's a certain inconvenience of quality of life with the 4 and 2 layers that you don't have with the Velcros. So we usually treat 4 or 2 depending on the leg shape. And then at that point say, all right, here's the deal. Long-term prevention, Velcro inelastic, compression socks. What's your pleasure? The problem is that insurance companies pay for treatment, not prevention. And so if they have an ulcer, they'll pay for 4-layer, 2-layer, whatever. Once you get the ulcer healed, Medicare and insurances aren't interested in prevention. They only treat active, which is stupid.
I agree.
So in our practice, for better or worse, these patients are told, here's the cost. Here's what it's going to cost out of pocket, socks versus the Velcro. Pick one. The good news is with care, those devices last 2-3 years.
Right. Mm-hmm. Yeah, good point. Excellent point. All right. Brian asked a question, and I'm going to take a shot at it, Brian, but if you want to clarify, because I'm not exactly sure, it says gold standard I know is compression. What should topical treatments be used combined? Well, obviously, I'm assuming when you talk about a topical treatment, I'm just going with Brian here. You're talking about the treatment for the wound. And obviously, the main thing with compression and topical treatments is that the frequency of your topical dressing has to kind of match up with the frequency that you have to change your compression bandaging system. You don't want a dressing you got to change every other day and then put a 4-layer wrap on them. So, that's it. But I mean, Brian, if there was something else you meant, send us a re-comment and clarify, because I don't know. I wasn't sure exactly where you were going with your question.
Now, one of the things that the question brings out, I don't know if he asked that, is what do you do in the case where they have definitive venous disease and massive drainage? I mean, high volume drainage. Because the problem is when you're using the 4 and the 2 layers, you're going to get strike through early on. And so how do you deal with that? And that's a problem because, once again, one of the things we teach is 11 diagnoses in wound care. If you diagnose them as venous, equal sign compression. The problem is, how do you compress in someone that is draining massively? That's where the wound care expertise comes in. Can you get a negative pressure system on that leg? Well, the problem is if it's single ulcers, you may get 1 or 2. Right. But the second point is you got to treat the cause. If it's venous and they're leaking from venous disease, if you don't treat the underlying venous disease, you don't get the leakage control. Right. So you got to pick your shots in these cases.
Right. Makes sense. One other question we got coming here, Doc. Obviously, it says adequate protection and padding of any bony areas is important for comfort and to avoid injury. What is your favorite, foam or cast padding?
Well, but don't forget, you don't need that because you're talking, you don't need the padding. We're not talking lymphedema here where you've got lobulations and sharp cutoffs. These are cloth-based. Layer 1 in a 4-layer compression, and arguably the layer 1, 2, and the 2 layers have padding in them. Layer 1 is a soft cotton padding. Layer 2 is where you get short stretch, layer 3 long stretch, but they come with padding. So there's no reason to use foam or anything else if you're using one of the standard kits, for lack of a better word. Right. But foam and stuff like that, you're thinking lymphedema, which is the sharp cutoffs, the lobulations, legs that look like the Stay Puft Marshmallow Man or the Michelin Man. No. In pure venous disease, no. There's enough cushion in there. You shouldn't have that problem. The bony prominences themselves, those wraps, assuming they don't roll, those wraps themselves cover a large enough area. You should not have concerns with point pressure.
Yeah, and I would say probably the only time you really need any extra padding is when you don't have a big enough circumference, because you have to have a minimal leg circumference. That might be something you have to add some padding in on that, but as long as the circumference meets the minimums, like Doc said, I think the padding in there should be sufficient to protect that. So,
in fact, sidebar, Bill, ankles, to give you guys, a great tidbit, we use 19 centimeter circumference at the ankle is the minimum that we will apply for a 2-layer compression out of the box. Otherwise, if they're at 19, we will take that layer 1 and add 3, 4, 5 wraps. We will put ABDs or foam. Why? Law of Laplace. I want to increase my radius to decrease my circumferential pressure. So 19 centimeters is what we use in our clinic. Gotcha. And I'll tell my staff, pat them out. They're at 19, pat them out. Pat them to 21, pat them to 22. Gotcha. It doesn't change the pressure gradient. Right. But again, little skinny old ladies can have chronic venous disease. And remember, the swelling is not necessary. Chronic means chronic. Lipodermatosclerosis, scarring of the skin and sub-Q. You get that inverted Coke bottle appearance, and they can still have venous disease. They can still have venous ulcers. So lack of edema is not itself a reason to not compress. Either you make the diagnosis of venous disease or not, and if you make it, equal sign, compression. Right.
I mean, I read something, and maybe you can correct me on this, but I thought I read once in an article that a person, depending on their normal their structure, you could have 5 pounds of fluid in a leg and still not really be exhibiting any pitting edema yet.
Correct. The
You know,
legs
so
are
you might look at that leg and be like, well, they're not really swollen. There's no pitting there. And I'm like, well, that's not the case. There could be 5 pounds extra fluid sitting in there.
absolutely. That's
So,
why you palpate the pretibial areas. That's why you palpate the perimalleolars, because that fluid can be dispensed. You know, again, if you've got partial lymphatic compromise, you know, the veins don't have to leak just at the bottom. You've got a saphenous vein that goes from the popliteal down to the ankle.
right.
Any of those perforators can cause problems.
Sure. All right, another question, Doc. The person says, studies I've read are showing that the fabric within the multi-layer wraps itself loses its pressure or strength after 2 days. So should we be doing this 3 times a week instead of 2 times a week or even weekly? Have you read anything about that?
I have not. In fact, I know that the manufacturers create these so that I mean, an ACE wrap is not going to lose its elasticity after 2 days.
Right.
And if you think about it, that's the layer you're talking about, because you don't want to have stretch in layer 2, your high working layer.
Right, right.
So that layer, you don't have to worry about losing it. I mean, if it lost what little stretch it has, that only improves its high working pressure.
Right.
Cotton batting, maybe it gets compressed. But layer 3 in the 4 layer, or layer 3, 4 in the 2 layer systems, those elastic layers are not going to lose their elasticity in 48 hours. It's
right. I would agree on that one. Like I said, I'd be interesting on that study. Gina, if you want to email me a copy of that study, I would be interested to read that myself, and even Doc might even want to see it, just to see where they're coming from with that. So let's see. I'm scrolling down here. Let's see here. We got, what is your advice for compression for a patient with venous ulcer, significant edema, poor kidney function, and CHF?
Fabulous question. You know, the problem is there's a lot of misconceptions about CHF. You got to remember that CHF is, if the heart is pumping against, high pressure, afterload, that's going to worsen CHF. But most of the fluid going back to the heart, other than through the vena cava, comes back through the lymphatics, or not most, a lot of it. And the lymphatics work constantly, sucking up constantly. So with CHF, what I do in those cases, and again, a great question, is, and I'm going to use a word that I hate more than anything else, but I'll explain what I mean. I will put them in light compression. I will put them in the 4-layer compression or 2-layer. But I will tell my nurse, go with about a 30 millimeter compression, go about half, and I will put that on. And then the next change, we'll do it again. And I do that. And I also talk to my nephrologist and say, hey, I'm treating lower extremity swelling. And 100% of the time they say, no problem, I'll dialyze off that fluid. Then once I over the next week or 2, move them to full compression, that leg is now locked in at full compression. So, but I do one leg at a time. So it's light for 2 weeks. Then I go to full. The nephrologist has got the fluid off. We're good. Then leg 2, light compression for 2 weeks. And again, I hate that term, but it's whatever. And then I've got both legs locked in. Then I don't have to worry about CHF. My nephrologist is happy. And at that point, I now have 2 legs that have no edema. My venous system is controlled. If they have ulcers, I continue till the ulcers are healed. Right. And again, then I don't have to worry about fluid. My friendly neighborhood nephrologist man has got that covered. Right. And then at that point, then it's okay, we're good. And then it's either into the Velcro elastics or compression hose or whatever. But a fabulous question. That's one of the only times where I do a stepwise incremental compression. Mm-hmm. But if you've got to treat the venous disease, and my war cry has always been, if you're not willing to do what's necessary to get them better, send them to somebody who will. Right.
And I think you and I, again, we addressed this on that previous interview. So if you want to check it out in our members only section, we did talk about CHF and stuff. And I like to kind of make it, in using my simplistic way of looking at it, CHF is a problem with preload. And compression cannot increase preload. No. And preload is managed with diuretics. Correct. But compression does increase afterload via the lymphatic system, and the kidneys manage afterload. So if you've got somebody with kidney failure, you've got to dialyze them to get rid of the fluid. If they've got normal kidney function, they're just going to be going to the bathroom a lot more frequently, but it's not a big deal. I
Right.
kind of
Veins have nothing to do with after.
exactly. The veins have nothing to do with the afterload. It's preload, and like you said, you can't push the fluid back into the vein. That's not how it works.
No,
So you can't.
no, it's
People think they're going to make their CHF worse. I'm like, how do you make the preload worse if you can't push fluid back into the vein? That just physically cannot happen.
the other thing is, remember, if you've got a compromised heart and you don't treat that lower extremity edema, you now have something with a weak pump trying to move two anchors.
Interesting.
And you can't.
Yeah.
The weights, 5 to 10 pounds of weight. You've got a patient now trying to drag 20 pounds of weight around. That's the other problem. You're stressing the heart by forcing it to move more weight.
Got another question that came in, Doc. And I'm not sure if I'm familiar. It might be a brand name I've not heard of. Not that because I can't say I know every brand. It says, what do you think about Tubigrip? I don't know if you're familiar with that product. And then wrapped with a 50% stretch and a 50% overlap Coban.
I'm going to apologize. I'm not familiar with the Tubigrip. My best guess is based on the ending.
She did clarify. Tubigrip is what she meant.
Right. And we've already beaten that yet. Again, the problem is high working pressures, low resting pressure, high resting, low working. And when you put a Tubigrip on, you're getting 8 millimeters of mercury with 50 out. When you apply a Coban, a cohesive bandage over it, great. You've now created a scenario of high working pressure when gastrocnemius soleus pumps against that. But when they're at rest and the swelling goes down, now the Coban is no longer attached. The Tubigrip's are dirty. So you're getting zero pressure at rest.
Excellent. Great. Terrific, Doc. Well, listen, I don't see any other questions on there. I think we kind of swatted this fly with a barn door, if I may say, using my own. I hope that our viewing audience found this interview tonight in our series here, kicking it off with Sherlock Holmes in the Case of Missing Evidence. I hope you found it helpful. It will be up on the Facebook Live for a couple of days for free, but eventually it will be part of our members only section at Wound Care Gurus. And so, if you've got somebody you want to refer to it, like I said, we'll have it up for a few days on YouTube and or Facebook Live. It'll be at Facebook, but just for a few days, and then it's going to be taken down and incorporated into our members only section that we're building up our content there for our members to really give them some great evidence-based stuff. But Doc, I want to thank you for your time. You and I have always had a great working relationship, and I've learned so much from you in the decade or longer that I've known you. You changed my view of wound care and a lot of things, especially with venous compression, ABIs, that whole thing. And so I thank you for participating. This is going to be a great team thing. Again, for those of you viewing, send us in topics that you would like us to take and address on Sherlock Holmes. We would love your input and your thoughts on things. You can, again, send it to us on Facebook via Messenger. You can certainly send it to our Wound Care Gurus email, which is customersupport@woundcaregurus.com, and send us your ideas. We would love to address those and take those apart on Sherlock Holmes in the future. So, Doc, it's been a pleasure. I appreciate you. Thanks for your time. Thanks to the viewing audience. Everybody have a wonderful evening, and we will see you all next month. Take care, everybody, and God bless you.